Dr. Salah Gariballa. He's Professor and Chairman to the Department of Internal Medicine, College of Medicine and Health Sciences, United Arab Emirates University. He will talk to us about obesity and heart failure. Will Professor Gariballa take the podium?
Thank you very much indeed, Chairman. And I'd like to thank Professor Kazam, the Chairman of the World Heart Failure, the President for the invitation and the organizing committee as well. And as you can see, my brief is to try and convince you that obesity causes heart failure or is a risk for heart failure. And I think for me to be able to do that, I need ultimately to prove that prevention or treatment of obesity would reduce the incidence or alter the prognosis of heart failure. But I will do my best. What I will do at the beginning, I will try and go through the evidence behind the relationship between the two. I will look at the strength of that evidence. I will look at the consistency and if there is a dose-response relationship, and also biological plausibility. I think some of this is common knowledge, so I will not dwell on it, but I'll make sure that I will also point out how we deal with patients with heart failure and obesity, or how to prevent heart failure by treating obesity. Before I do that, I'll try and give you some idea about the epidemic of obesity worldwide and here in the Middle East. Now in the world, as I speak, we have 2.1 billion people who are obese or overweight, and this is 1/3 of the population, according to the latest World Health Organization report. This is likely to increase to more than 3 billion or 3.5 billion. Half of the world population are likely to be obese, 2030. And this is going to be more so in developing countries, unfortunately, because developing countries are the least equipped to deal with these epidemics. As you can see from the slide on the left-hand side, obesity has doubled in sub-Saharan Africa recently, in some of the Middle Eastern and Asian countries, and this is just up to 2008, and this is likely to triple in the near future. If you look at the right-hand side of the slide, one consequence of obesity is prevalence of diabetes. And as you can see, diabetes, 2003, 21% have impaired glucose tolerant test in developing world, rising up to 26%, 2010, and projected to be 47% by 2030. Likewise, type 2 diabetes, 7%, 12%, 23%. This, if continues like this, and as you know, diabetes is just one risk factor, this is likely to reverse all the healthcare developments and healthcare improvement over the last 50 years, and has the potential to lead to significant economic and social detriments. Furthermore, the projection of the World Health Organization recently is every 4 out of 5 diabetics in the coming 20 years are going to be in the developing world. And this is just one consequence of obesity. What about the UAE here and the Middle East? We have limited data, but from the data we have now, in men, 7 out of 10 men are obese or overweight. Women, that is more so. But our problem is just not obesity as defined by body mass index. Our problem here is central obesity as opposed to general obesity, and I'll tell you why as I go along. Before I move on, I just want to shed some light on the causes of obesity, which is important. I know that everyone agrees that there's been an increase in food production and availability recently, and that's one factor. Also, the change in the physical environment made people lead sedentary lifestyle, very limited chance for physical activity, and that's an important factor. But within those factors, there is a very good scientific information coming through that if you are genetically predisposed and living in this environment of plentiful of nutrition, you're more likely to be obese than someone who is not genetically predisposed. And on the human genome, 32 regions on the DNA have been found to be related to body mass index. And one of them, which is being characterized recently, is called the FTO gene. If you have the FTO gene, you will not be able to control your appetite as someone who doesn't have the gene. And therefore, your appetite is under a very strong biological control. So you just eat and grab what is around you. And that's an important factor. Also from twins studies, we know that obesity can have some genetic component to it. But that is very early, and it is not important as far as an individual patient management is concerned. It is important when you look at the population as a whole. I'm not going to dwell on this. Everyone knows that obesity causes hypertension, diabetes, dyslipidemia, etc. Inflammatory markers increase and therefore induces heart failure. And this is plenty of knowledge. Early on, I referred to a meta-analysis from published in the BMJ last year in school-age children, which showed that overweight children compared to those with normal weight have increased systolic blood pressure, diastolic blood pressure, and also insulin resistance. And that's reflected into increased left ventricular mass, more so in those who are obese than overweight. So there is a dose-response relationship here. This is a very important and landmark study, Framingham Studies, which followed 5,880 people over 14 years and measured their body mass index and looked at the incidence of heart failure and found that heart failure occurred in 496 people over 14 years and showed that there is a dose-response relationship between obesity and incidence of new heart failure. And so many studies followed this study. Not just that, Professor Stewart early on emphasized the fact that heart failure is a disease of men. This study has shown that if you have 1 unit increase in body mass index, you have 5% chance of being obese as a man and 7% chance of being obese as a woman. And that's important. And as you can see, these figures reflected there. So further studies have looked at body mass index, but also looked at waist circumference, which, as you know, body mass index measure general obesity, waist circumference measure central obesity, and that's important. So there are lots of studies, and I think the evidence is very robust here. And many of the speakers have alluded to this. So I think we have to accept that obesity causes heart failure, full stop. Now, there is something else which is important and coming through. Obesity causes heart failure. But if you are obese and have heart failure, your prognosis is better than having heart failure without obesity. And this is the term called the obesity paradox. It's been coined recently. And this is coming through also very strongly in so many studies, and this is one of them, 263 hospitals from the United States, including 8,000 people who developed heart failure. And they looked at mortality and body mass index, and as you can see, the higher the body mass index, the lower the mortality in hospital. This has been replicated in so many studies, but also it has shown that obesity increases improve heart failure prognosis. But I have to emphasize that's overweight and moderate obesity, mild to moderate obesity, that body mass index of 30 to 35. Higher obesity, 35 and above, or normal weight doesn't lead to improved prognosis. This is happening in people with improved normal left ventricular function and patients with reduced left ventricular function, and also in acute heart failure and in chronic heart failure. So both. And I didn't bring all the studies, but I'm just, you have to take it from me. The other also information is obesity paradox also happen in people coming with acute coronary syndrome and people coming for PCI and cardiac revascularization. So it's consistent across the board. What are the mechanisms behind the obesity paradox? Now we're saying obesity causes heart failure, and then once heart failure has happened, then obesity improves the prognosis. That doesn't make sense. There are lots of speculative mechanisms. Some of them have been with evidence behind them, some of them have no evidence behind them, but I'm just going to go through one or two of them. As you know, when you have heart failure, you have lots of immunological, humoral, and nutritional changes, which we call it cachexia or cachexia, which lead to poor prognosis. Some people say if you have obesity, you have more metabolic reserve, and that's for you survive longer. Others say if you have obesity, you have more fat cells. These fat cells secrete lipoproteins, and these can neutralize the cytokines. Specifically, as we heard from Professor Rosano the other day, that if you have a high TNF alpha, that will increase your risk of weight loss and poor prognosis. So if you have obesity, you secrete lipoproteins, and then you neutralize that, and also soluble TNF receptors as well. A very important information coming through that obesity patients have attenuated renin-angiotensin-aldosterone system. Despite that, they have a high blood pressure, and that high blood pressure can improve the renal function. And also, they tolerate anti-obesity or anti-heart failure treatment better than those, and likewise the sympathetic system. They present early because of that. One area, increased muscle mass and strength. That might be leading to a better cardiopulmonary fitness. And cardiopulmonary fitness is in obese patients actually improve outcome, improve prognosis, and obesity paradox doesn't take place or is not present in patients with heart failure who have a better cardiorespiratory fitness compared to those who have a lower fitness, and that is thought to be due to an increased muscle mass and increased strength. I'll come to that in a minute. But the thing is, obesity paradox is not confined to heart failure. This is a very big study. Many of you might have seen it. Meta-analysis included 2 million people from America, not just obesity, everybody, and found that if you are overweight, that will reduce your chance of dying if you are obese and overweight compared to someone who is extremely obese or just obese above 30. Mild obesity or moderate 30 to 35 doesn't increase mortality. Overweight protects you compared to normal weight, but having higher obesity increases your chance of dying. So it is not just heart failure. It's also in hypertension, diabetes, hemodialysis, and cancer recently, that there is an obesity paradox. What is the explanation for the obesity paradox? I think there is a limitation of the body mass index. As you know, body mass index takes the weight divided by square height in meters. It does not measure body fat, and that is the most important. And it does not measure the distribution of body fat in the body. And these are two important issues. People can be obese, but they can be fit athletes, have a lot of muscle mass and fat-free mass. And vice versa, people can have normal weight and have a lot of fat in their body. And this is what been called recently normal weight obese people. And this is a very important concept. It depends on the amount of body fat and the distribution of that fat. The best slide which can summarize this or summarize the limitation of body mass index, these are two professors one from the UCL and one from India, Professor Yankin and Professor Yutkin. As you can see, they're friends. The body mass index is 22.3, both of them. But look at the fat mass, measured using dual X-ray energy. Their fat mass, 21% in Professor Yankin and 9%. There are differences in these two professors. This man ran a marathon. This man doesn't do exercise. In fact, he said the only exercise he does is running in the morning to beat the closing door of the lift in his hospital. Otherwise, he doesn't do any exercise. And also, his birth weight was smaller compared to Professor Yutkin. And his risk of disease is significantly different. And they have the same body mass index. This is called the YY paradox, published in the Lancet 2004-2005. Sajid, what's happening here? So this underscores the limitation of the body mass index. And take it from there, many of you have aware of the inter-heart studies, included 29,000 people who developed heart attack from 52 countries in the world. And the only time people from the Arab world has been included, and shown that body mass index does not increase your risk of heart attack if you adjust for all known risk factors, while waist circumference does, even when you adjust for risk factors. And this is important. Published in The Lancet. Again, it showed that the higher waist circumference is the increased risk of heart attack, the lower and the bigger hip circumference is the lower risk of dying of a heart attack. So if you want to prevent heart attack, you increase this and reduce this. Why that's the case? Because there are fat. If fat is central or visceral, it's different from being gluteal or being subcutaneous. And people have thought that the fat cell is just making the space in obesity patient. Now it is being shown to be a fine endocrine organ, secreting all these substances, talk to all these organs, and this is a risk behind all these diseases. So cytokines of all type, adipokines, adiponectins, etc., leptin, resistin, and so forth, these all are secreted by the fat cell. And not every fat cell secretes these substances, the one present in the viscera. And that's important. So this, what thought to be behind the mechanism of why people with central obesity have. This is a very interesting study published recently. Normal weight patients with increased body fat, body mass index normal, but they have significant left ventricular diastolic and systolic dysfunction and insulin insensitivity compared to patients with normal weight and normal fat, body fat. So it's the body fat, it's not the body mass index which affect your... So we know that... sorry, I think I missed the slide. We know that hemodynamic changes and structural changes do happen in obese patients with heart failure. And we know that preventing or reducing obesity or improving obesity or reducing weight does improve systemic and filling pressures, also improve left ventricular function or mass and oxygen consumption. We know that. I think there is plenty of evidence for that. But having said that, we don't know what to do with patients who are obese and having heart failure. What to do? Do we follow the guidelines for prevention of obesity before heart failure happens? Or do we say to an obese patient with heart failure, you have to reduce your weight back to normal? That's very difficult as present. And why? Because all the studies which looked at diet, exercise, bariatric surgery have shown it's been small, it's been short-term and inconclusive. So there is no evidence, and this dilemma is reflected in the European Society of Cardiology, which all they said is follow the guidelines for prevention of obesity before heart failure develop, but there is lack of evidence. Likewise, the American College of Cardiology. So if you have a patient with obesity and heart failure, what do you do? It's difficult. The answer is not easy, but I can give you some insight. I think we have to agree that the association of obesity and improved survival in heart failure is very consistent and almost there, but we need further research into the relationship between ectopic fat or subcutaneous fat, visceral fat, and biochemical activity, and that's what seems to drive the pathology behind obesity, and including heart failure. We need a better understanding as to why people with cardiorespiratory fitness are better in terms of outcome when they're obese and having heart failure compared to those with less fitness. And this is important, I think. And there is no doubt further research is needed also into to help improve the hemodynamic function, or look at the improvement in hemodynamic function and cardiac structure and in relation to body fat. But I have a suggestion for you. You're all cardiologists. I'm not a cardiologist. This is the father of American cardiology, Professor Paul Dudley White. He's a personal physician for the American President, Eisenhower. He worked at the Massachusetts General Hospital, and he used to cycle to the hospital up to the age of 80. And because of that, when he sadly died, a bike path has been named after his name. Many people believe Professor Dudley has saved more lives by people following him, by cycling to work, than putting a stethoscope to flesh. And this is important. So if you want to prevent heart failure, throw your stethoscope away. That may be difficult for people who are, they will still continue listening, I'm sure, especially for traditional cardiologists. And get on your bike. Lead by examples. Physician can help prevent heart failure or obesity by engaging in healthy activities, and their patients will follow. Thank you very much indeed for your attention.
Thank you very much for your elegant presentation. I am sure there will be comments and questions on this. Anybody likes to ask anything? I think, let me ask you, partly some comment also. I think we have been in India going through this phase of metabolic syndrome, central obesity, and of course hypertension and epidemic of coronary disease, diabetes. I think probably now we have around 50 million of diabetes in the country. One factor which I think is being also considered is that we have been for the last 2 decades consuming polyunsaturated oils, because that was thought to be low in cholesterol. And when it was realized that omega-6 and omega-3 ratio is very high in these oils, that they are not very healthy. And I think now there is a trend, I think, to have oils which have a good omega-6 and 3 ratio less than 5 or so kind of a thing. Can you just tell me what are the kind of oils being used in your place?
Oil, you mean? Polyunsaturated fatty acids?
Yeah, that's
okay. Well, the most famous is omega-3. We know that omega-3 have been shown in the Italian study to reduce the risk of arrhythmias, and people are now advising people to take 1 gram a day, for example, and that is probably not being shown fruit because of the maybe the balance between when people take fat, they take omega-3 and omega-6. Omega-3 is protective. Omega-3 is pro-inflammatory. And the balance between the two is very important. Again, there are 2 types of omega-3. One EPA, as you know, and then DHA. The balance between these two also is important. But what I say is, it's not the amount of fat. We know you have to take, for example, 35% of your diet is fat, but 10% of saturated fat. That is not important. I think the total energy is the most important part. The second thing I suggest is the fat, the most deleterious and damaging fat is hydrogenated fat. When you get that flora and they spread the hydrogenated, the vegetable fat, that is the most damaging, and many countries now producing legislation to reduce hydrogenated fat intake, and also putting a food label on that. But the amount of fat, as long as you keep it 35%, 10% saturated, and the balance, it's very difficult from a dietary point of view to decide which one to take in terms of monounsaturated fatty acid, apart from olive oil.
Yeah, please.
Thank you, Professor Salah, for your great presentation. Also for the best recommendation to use the bike. I used it in my previous workplace in Vienna. It was for me, let's say, a must. Here it's a little bit difficult, you know, in this part of the world. You will not die from cardiovascular risk, you will die from car accident. But this is the first recommendation. The second recommendation to let the stethoscope away, I will not follow it because I am telling everyone, every resident, every GB, if you don't have a stethoscope, then you are wrong in place. My question, for sure, BMI is, I think, a little bit difficult to deal with this with cardiac patient heart failure. Is there any gray area where you would say we should drive our patients there? I mean, BMI above 40 shouldn't be, under 30 shouldn't be, I don't know.
Well, the BMI?
Yeah, if there is a gray area for you to say this is maybe where we should drive our patients there.
Well, I think the answer is if you have a better way of measuring body fat and the distribution of that fat is better than the BMI. BMI has been shown. In fact, the Interheart study made it very clear, published in the Lancet, and I gave you the reference. BMI is useless as a measure of obesity in the Middle Eastern population. That's one answer, but I have to go back to your first assumption that if we don't die with heart failure, you will die with car accident. No. From a societal point of view, if you have many people developing heart failure, ischemic heart disease, stroke, all the money will go there. And I know you there. Most of the money is going to your cath lab in the hospital, where we don't get any on the medical side. Dr. Mustafa is always complaining that we don't have money to prevent obesity. If you give us half of the money you spend on the cath lab, or 1/3, we can prevent all cardiovascular complications and diseases.
Well, I think as a cardiologist, I need to say that I think both are important.
Yes.
Because I think you can't say that you don't have these facilities, because that's important. When you detect a disease, that you should be able to help them and some kind of treatment. So I think both are important. I take your point. I think we'll have to go into...
No, I just need to emphasize. I didn't say they're not important, but they have to be equally important.
Yeah, please.
I have a comment. I agree with you. Charity begins at home, and physicians have to engage in healthy behaviors. One of the things that we have that is very underutilized, everybody that we know, at least I know, has a smartphone. And no matter what smartphone you have, you can download an app which is called pedometer or steps. And I regularly show my patients how many steps I did per day. And my goal is 10,000. I barely ever reach 10,000 steps a day. But if I reach 7,000, I'm happy. So if you try to do that yourself and you show healthy behaviors to your patients, it always helps.
I think this is an excellent idea. And just to emphasize the point, we planned a survey in England a long time ago, and we gave people pedometers to measure their exercise. And a week later, we found them walking with the pedometer on the dog's legs, walking around. So I think the smartphone is an excellent idea, and I think we have a project coming through using this technology soon.
I think I have a short comment, because what is Professor Gariballa mentioned here, that busy slide is as obesity is lead to one of the arms is sleep apnea. I have been running a project about the sleep apnea cardiovascular relation to hormonal activation, and then we have seen a lot of patients. They are very obese, and the problem of obesity, when it leads to sleep apnea, you get the premature hypertension and diabetes. So if you have family history of diabetes and hypertension, instead you get your diabetes at 45 or 50, you will get it at 30. So that is a very important point, that the relation between obesity and the sleep apnea and cardiovascular risk factor.
I will not disagree with the chairman, absolutely not.
Well, thank you so much. I think thank you so much, Dr. Gariballa, for your excellent presentation.